Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Charles Howley, NAUTO's Director of Projects, who will start today's session. Charles, you have the stage.
Good morning, everyone. Thank you all for joining us for today's symposium on using data to address healthcare inequities and their causes. Today, this session is on measuring variation in health utilization, and we're really excited to have you all here. Today, Nick Faulkner will be with Comagine Health will be moderating this session, and I will bring Nick on stage to introduce the first presenter.
Thanks, Charles. Yeah, we have three absolutely wonderful presentations today. I'm happy to first introduce Jenny Howley and Jesse Sagona, who are from the New Hampshire Department of Health and Human Services, and their wonderful presentation on sub-county data analysis.
Hi, thank you for having us. I'm Jennifer Howley, and I'm presenting with my colleague Jessica Sagona. We are data analysts at the Bureau of Public Health Statistics and Informatics at New Hampshire Public Health Services. Jawei Chawla is the bureau chief of our bureau, and Kathleen Bush is the program manager of the Environmental Public Health Tracking Program, or EPHT, for New Hampshire. She's been very involved in this work we are presenting, which is titled Challenges and Opportunities in Sharing Sub-County Hospital Discharge Data. So today we will be talking about some challenges we have come across when working at the sub-county level, and it mostly comes down to issues that we have with data sharing and data gaps. Our key points are that states may be missing large numbers of hospital visits when residents go out of state for their care. Existing interstate hospital discharge data sharing agreements may have difficulties or challenges, and there is a need for a facilitation of data sharing agreements by a legal team. So to start, a little background on hospital data that we know are missing. New Hampshire is located in the Northeast US, and we have 3 neighboring states, which are Maine, Massachusetts, and Vermont. Here now are those 3 neighbors around New Hampshire, and on these maps are symbols that are showing locations of hospitals. And as you can see, all along the state lines shared with New Hampshire, there are many hospitals, which is many opportunities for New Hampshire residents to go out of state for their healthcare. And also important to note is that the opposite is true. There are many opportunities for those out-of-state residents to come into New Hampshire for their care as well. Back prior to 2016, we used to have data sharing agreements with all 3 of our neighbors, and that allowed us to receive their data for New Hampshire residents. With those years of data, we're able to see how much having the data from those out-of-state hospitals influenced our understanding of healthcare utilized and rates of ED visits and hospitalizations for specific health outcomes. Here's an example of age-adjusted rates for AMI, or heart attacks, hospitalizations by New Hampshire County. So each graph here is a county of patient residents. The x-axis has years from 2012 to 2015, and the rate is on the y-axis. And the red line shows the rates when we only use hospitalizations at the New Hampshire, that were at New Hampshire hospitals. And the blue line shows the rates when we also include hospitals from our neighbors. And we can see how some counties have a fairly large difference in rates when we are able to include these out-of-state hospitals. And these are counties that are near state lines. Rockingham is a southern county bordering Massachusetts, and Carroll is an eastern county bordering Maine. And you can imagine that if we broke the geography down into communities that are within the counties, some communities will be even more affected by the inclusion of out-of-state hospitals. Other health outcomes look really similar to this, revealing to us that out-of-state data is very important when we want to look at any geography that is finer grained than overall state rates. For the next part, I'm going to pass it off to Jessie.
Thanks, Jenny. So as Jenny just said, in New Hampshire, we definitely understand the impact of missing data from our neighboring states, but we're less sure about what the impact might be of missing data from further away states, and we wondered how substantial that might be. So to gain some insight in that, we could actually look at our own data of other state residents visiting New Hampshire hospitals. And here's what that looks like. So this is a table of New Hampshire hospitalizations in New Hampshire, hospitalizations and ED visits in the two right columns, and the left column is patient state of residence. So of course, we see more New Hampshire residents than anybody in New Hampshire hospitals, and then our three neighbors are next, and the table actually goes all the way down to include all 49 other states. So we thought, like, knowing that 49 other states worth of people are coming to New Hampshire, are New Hampshire residents also going to the other 49 states? We weren't sure about that. There's not an easy way to find out. So what we decided to do is we reached out to colleagues that are from the National EPHT Network and asked them to provide an equivalent table for their states. And 8 states answered our call, and they're shown here on this map and in the list. So including our own New Hampshire data, we ended up having basically 9 states worth of hospitalization data organized by patient state of residence. And so to try to make sense of all that, we started by making a heat map. So this is just showing New Hampshire only to start. On the x-axis, we've got patient state of residence. This is all 50 states in alphabetical order, and every third state is labeled for clarity. On the y-axis, we've got mileage buckets that indicate the distance, approximate distance between the patient state of residence and the state where the person was hospitalized. And then finally, the colors represent how many cases fell into each combination of state of residence and mileage bucket. So you can see, looking at Vermont, Vermont is one of our neighbors. It's less than 500 miles away from New Hampshire, and it has well over 1,000 visits per year to our hospital. So therefore, it's the darkest purple color. So just seeing New Hampshire's data here doesn't necessarily tell you a lot, but if you add in a second state, for example, Oregon, you can see how the chart starts to fill out. And then when you pull all 9 states together, the map looks much more colorful. You can see that there's a lot less, excuse me, white and gray cells, and these the 1,000 or greater cells, the darkest purple, range as high as 23,000 actually in this heat map, which is a pretty impressive number. And we think this plot is interesting for a couple of reasons. One is that it shows you that people go to the hospital in places that are really far from home pretty regularly. And we also think it speaks to the importance of the combination of visits across other states. So even if state X's residents aren't really hospitalized in state Y in great numbers, when you start to add up the hospitalizations over lots of different states, you might start to see something more significant that the state of residence might like to have that data. And our understanding is that a lot of states don't receive hospital discharge data even from all of their surrounding states, let alone states that are further away. So we think that a lot of states probably aren't aware of this data and certainly don't know anything about why their residents were going to the hospital in these other states. Now I'll turn it back over to Jenny.
Great, thanks. So we've made the point now that it's very likely that every state out there has data on our residents and your residents that would be worth having. But even when we do share or receive data from other states, it can still have challenges. And a big one is receiving inconsistent data elements, especially when it comes to geography fields. For example, due to privacy concerns, address level data is not provided. This is problematic as we attempt to geocode all records to an exact lat long, and we use that to identify census tracts that the patients reside in. We often use census tracts for our sub-county analyses, as this allows us to look at the data through a health equity lens and assess rates of health outcomes along with social determinants of health that we can get from census data. So having reliable rates at the census tract level is very important to us. In addition to not receiving address data, we sometimes get zip code instead of town. And this is an issue for us because all of our geocoding is done at the town level. And that means that we are applying different methods of geocoding to our in-state records versus those out-of-state records. Also, receiving zip code can cause issues when zip codes cross town lines, and almost all zip codes cross census tract lines. Another issue with sharing data is timeliness. Though we have not received data from all 3 of our neighbors since 2015, even when we do receive that data, the timeliness can lag from the availability of our own data. So here's the same plot shown earlier for AMI hospitalizations, only this time we have shown our in-state rates up through 2019. And we now have the question of what data do we share publicly on our data portal or with our partners? Do we only show the data through 2015 since it's the most complete? Yeah, as you can see, it's very outdated. Or for the sake of being most up to date, do we show only in-state data, but warn that the rates may actually be higher than shown? We don't have an answer to this, and we'd love some thoughts. And finally, just getting assigned a data sharing agreement itself can be a huge challenge. There are concerns about how the data will be handled, who will have access to the data, and how the data will be stored. Also, concerns about privacy and sharing identifiable information. And while these are critically important issues, it's also important that analysts have the information they need for their analyses and are able to accurately aggregate and summarize the data. So we see a need for legal counsel to understand the importance of obtaining detailed geographic information, as well as sharing it, and for the purpose of revealing sub-county patterns and highlighting areas to improve on health equity. So we have a couple of potential solutions that we'd like to propose. One is a nationally facilitated exchange of hospital discharge data, where a national organization pools the out-of-state data and provides it to states of patient residence. This would be the largest lift, but it would absolutely have the greatest gain. Another helpful solution would be to have a nationally standardized data sharing agreement that all states can use for the exchange of hospital discharge data. And finally, we're open to other ideas as well. We'd love to be a part of a discussion with other states, agencies, or organizations. So that wraps up everything we were wanting to share. We'd like to thank the National ePHD Network for facilitating many conversations and pilot studies. We'd also like to thank our ePHD friends and their colleagues at the states that participated in this out-of-state project. Thank you so much for your time, and we look forward to questions and discussions.
Excellent. Thanks. Thanks for that wonderful video. Super interesting, informative. And yeah, as Charles is putting on the screen there, don't forget, while the session video is going, you're more than welcome and encouraged to put questions you might have into the chat, and the group will try to address those or discuss those as we get into the QA period. So I think there's a couple of really interesting points that were made in the video there that I think could warrant a lot of other discussion and most likely could be relevant to others in the audience that we should probably chat about. You spend a little bit of time talking about the geography and the geocoding limitations you're facing with the data you're receiving from other states. Are there any other elements that you're aware of that you're also missing that you'd like to have or that are posing challenges for you in your analysis?
Yeah, I'll take this one. We know that from certain states, we also don't receive information such as patient date of birth and some race and ethnicity data, which when we are trying to bind that all together with our data set and look at health equity or health disparities, that can really be an issue when all of those out-of-state patients really come in as unknown.
Excellent. Do you think this limitation is mostly just a lack of sort of common data types or mapping, or is it a data sharing issue, or do you have any idea about why this would be a problem?
It really comes down to being a data sharing issue. A lot of other states are, they just have restrictions on what they're able to share and what they consider identifiable information. And so being able to provide that data, it becomes really tricky when it comes to those legal challenges.
Got it. Yeah, that makes sense and is certainly a challenge. You mentioned a number of states in the pilot. Among the 9 states that were in the pilot, did all of them see visits from other states, as you guys were seeing also?
Yeah, I could take this one, Nick. So when I was running those numbers, I checked to see if it was going to be 49 states for each of the other 9, like you said, and there was only one combination that was missing out of 49 times 9. So pretty close.
Wow. So obviously it may be a little bit of a leap, but I guess the assumption there is that other states are probably in a similar position to you guys, where they're seeing multiple out-of-state visits both ways, right? Either their residents are going to another state, or other residents are coming into your state and receiving care, and maybe missing some of the data there. So that's an interesting revelation, I guess, that others are probably seeing the same thing. There's a question just came in the chat. I'll throw that one to you guys. The question here is, did you find there was a difference between the most prevalent diagnosis and procedures versus in-state versus out-of-state hospitalizations? So did you see any kind of correlation between leaving the state intentionally to receive certain healthcare versus emergency versus, vacation, business, et cetera, visits? But is there any way you could tell any of that kind of information from your analysis?
We haven't been able to do quite that in-depth of an analysis yet, but from the indicators that we most commonly look at, it really just seems to be kind of convenience for the people who live near the border towns. Sometimes the closest hospital actually just is across the state line. And we are just noticing that patients don't really care about state lines, and they're going to go to what's most convenient for them. So, and then I think we mentioned before, maybe, but Boston is very close to us. So it has a lot of very large hospitals. So we do notice that for some more of the more serious complications, people are often transferred to Boston. So getting that data from Massachusetts is really important to us for understanding that.
Excellent. And then another question that your presentation sort of brings up is you mentioned the geography data and other things that might be missing. What other record level hospital or ED data do you think you could be missing?
Sure, I can take that one as well. So during this out-of-state project, we realized that a couple of the hospitals were actually receiving their VA data, which is something that we in New Hampshire do not receive at all. We do have a VA facility here. And so that was something that was interesting to us. And so we're wondering, do other states also receive VA data or even military hospital data? Some other things that come to mind are there's a bunch of freestanding emergency or departments or urgent cares that are not affiliated with hospitals, and we don't receive data on any of those. And so we're sure that we're missing a lot of data, and we don't know exactly who's visiting those types of facilities for what, and that would be really great data to have. And the last thing I can think of would be prison facilities. I know that's been an issue during COVID, not really having a great grasp on cases of COVID in prisons, or just understanding who's hospitalized and what kind of facilities the prisons have, and at what point do they transfer to out of prison facility hospitals. So those are the ones on the top of our heads for now, but I'm also curious if there's others that anybody else has thought of.
Excellent. Well, that was a wonderful presentation, much appreciated. I'm sure that it spurred a bunch of conversation and things to think about for others who are undoubtedly experiencing some of the same issues you all are experiencing and uncovering in neighboring state data. So much appreciated. Up next, we have a presentation from Steve Mooney, who is the Assistant Professor of Epidemiology at the University of Washington, about small area estimates and data. Charles, can you start that one?
Hi, my name is Steve Mooney. I'm an epidemiologist at the University of Washington, and I'm going to be talking about some work I did to compute obesity prevalence from electronic health records in populations. So the background here is that I was a programmer before I turned into an epidemiologist. I'm currently at the University of Washington in the epidemiology department, and also the associate director of the research core at the Harborview Injury Prevention and Research Center. And I'm broadly interested in place and health and big data kind of stuff. So the core question we're going to be talking about today is, can we use health system data to create population-based research or surveillance work? And so the core underlying issue, the thing that makes this complicated, is that a healthcare delivery system doesn't engage the whole population. So for example, in the Seattle area, we have the Kaiser system, which provides managed care as it does in many other places, where the population is mostly a stably employed middle class set of folks. There's also UW Medicine, which is an academic medical center, which includes both some specialists who do very specialized work, but also is the fallback emergency care system across the region. There's a private hospital system called Swedish Providence that has typically higher income folks. There are community health clinics like Seymour that typically engage lower income folks. And then of course, there's some folks who never engage with the healthcare system at all. And so when we have healthcare records, we'd like to think that any research we do on them can apply to the whole population. When we teach science, we teach the sort of idealized model where we have a source population, we sample randomly from that. We maybe give, in a randomized trial context, we assign some treatment to some of the people, we observe some outcomes, and we know in the end that the effect that we estimate is relevant for a target population, which is often the source population we sampled from, but not necessarily. But in practice, if we're doing science on health system data, we've got something more where the source population experiences some life events independent of anything that's under researcher control. That results in being exposed to the treatment of interest, being recorded as having been treated, having a recorded outcome. And so it's really unclear in the end who any population-based research results might apply to. And this problem is considered a selection problem. So there are three really common approaches to this problem. The first is to sort of throw our hands in the air and say, this is a limitation, there's selection bias, we don't know how big it is. A second, maybe more common and a little bit more sort of conservative from the inferential standpoint is to say, well, we know that these were the people who were engaged in care in this system, and we can use, we know a lot about those people, so we're going to limit our inference to people who are those people who were engaged in care. And for any question that's like, what should this care delivery system do? This is a fair limitation of inference. But in general, in research, we'd like to come up with truths that are generalizable. It'd be nice to be able to say that a given intervention, say, works across any population, not specifically within a given care system. And so another sort of approach is to say, well, let's aggregate. Let's say we know that not everyone is included, but we're going to aggregate and do our best there. And so I think that's a good approach, but I also want to explore how much bias there is and whether we can correct for it. So I'm proposing in this talk to think about how much the health system we choose affects our estimates and whether we can correct for them. This talk is going to go through a case study looking at the prevalence of obesity among residents of each census tract in King County. I'm trying to estimate it in the broader population. This case study was picked in part because it's available, because obesity is spatially patterned, so we expect some variation. Place is easy to get in the medical record. BMI is easy to get in the medical record. And so we're able to look at this as a sort of good sample case of how much is the population selection affecting our inferences. So just to set you up analytically, I'm going to look at the obesity prevalence by tract as computed by data from primary care visits to two different health systems. So analysis one is comparing one health system, Kaiser Washington, against another, UW Medicine. The second analysis is to compare obesity prevalence by tract as computed by health system data with obesity prevalence as computed by survey data. So I'll talk more about that when I get there. But first is health system, then it's health system survey. And so the health system data, I'm building on some prior work that some colleagues had already done to look at obesity prevalence in the Kaiser Washington primary care population from 2005 to 2006 in King County, Washington. This map sort of shows what that looks like. In general, so blue areas have higher obesity prevalence, and as you can see, there's more obesity in South County and less obesity in the core Seattle area. And this is not unexpected based on sort of general population demographic trends. But in order to compare to what those estimates would look like if I used UW Medicine data, I first extracted height, weight, and home address from primary care visits from 2005 to 2006, so to match the same time window. I'm limiting to one visit per patient, so people who visit more often aren't weighted more heavily in the estimation. Geocode each patient address to identify the census tract that it's based in, then compute an observed prevalence of obesity in each tract, and then use something called an empirical Bayes correction to correct for the fact that there are different numbers of people in each tract. And so the empirical Bayes correction is a very blunt way of dealing with this selection problem. But it basically says, in tracts, if you think about it, if you had 3 people in a tract, you only have 3 values for the possible obesity prevalence. It could be 0%, or sorry, if you have 2 people, it could be 0%, it could be 50%, or it could be 100%, depending on how those 2 people end up. As you get more and more people, you get more nuance in sort of the ways that this can play out. So the empirical Bayes correction is a way of saying when you have small numbers, shrink your estimate towards the grand mean. So for looking at this plot, showing the Bayes correction on the x-axis is the raw prevalence of obesity in a given tract. On the y-axis is the corrected prevalence, and the size of the dot indicates the log of the count of patients in that tract. So very small dots are tracts with very few patients. So this tract had very few patients in the UW medicine data, and 0% of them were obese, this top tract that the arrow is pointing to. And so the corrected estimate is very close to the grand mean. We had very few patients, and so our best estimate is much closer to the grand mean. The bottom arrow is pointing to a tract that had many, many more patients, but none of them were obese. And so our best estimate of obesity is much further from the grand mean for that one. In other words, the correction corrects less. And so we take this approach and compare the Kaiser Washington population in 2005 to 2006 to the estimates we would get from the UW medicine population in 2005 to 2006. It's a fundamentally similar pattern: more obesity in the South County, less in that core Seattle area, and more generally, this kind of like a spatial autocorrelation where tracts that are prevalent, where obesity is prevalent, tend to be near other tracts where obesity is prevalent. Interestingly, UW had a somewhat lower obesity prevalence overall, which is a little unexpected, which I can talk about if folks are interested in why we think that's happening. It turns out that during this time frame, the CDC's Behavioral Risk Factor Surveillance Survey was asking Washington State residents for the cross streets of the intersection nearest their house. And so some folks at the Seattle-King County Public Health Department used this to generate BMI estimates by tract for 2012 to 2016. And so we can compare that to the UW medicine data for the same time frame. And so where the first comparison was health system data versus health system data, this is the health system data versus survey data. And so what we found, we did the same process of extracting height, weight, and address, but this time limited to 2012 to 2016. And what we found is a very strong, very similar pattern between the Burfus estimates and the UW medicine estimates. Interestingly, there was a generally lower prevalence of obesity in Burfus, possibly because self-reported obesity prevalence is typically lower than obesity prevalence as computed when you actually weigh people and measure them. And so, like I said, the empirical Bayes correction helps these. We end up with very similar values, suggesting it doesn't matter a ton what health system we took the data from. The empirical Bayes correction is a blunt tool. We might be able to get more accurate by using a more complex correction scheme, understanding the selection processes that get patients into the population. And I'd like to explore changes in prevalence over time. And I'd also like to talk to folks who are attending this symposium, because maybe you have similar issues in your data, and we could look together at how representative your data might be in your geographic context. So with that, thanks for listening, and I'll stop there.
Excellent. Thanks, Steve, for that wonderful discussion. Very interesting, as expected. I do see a really strong glowing line between the first presentation we saw about the sub-county data analysis and the out-of-state utilizers, and was wondering if you found any amount of that. Did you account for that? What are your thoughts on how that may affect your analysis?
Yeah, thanks, Nick. That's a great question. So my data were limited to people whose addresses, whose reported home addresses or billing addresses, I guess, actually geocoded to King County. I didn't have access to other data owing to the way that the data request was structured. And so I wasn't able to look into the stuff that the New Hampshire folks did. I would love to be able to look at that. I think, a key, one of the things that I think is tricky is for something like obesity prevalence, people are probably not going out of it's basically a sort of well visit type of issue, right? The people are not looking to see a specialist in order to get weighed. You don't need to go out of state to be weighed or measured for height. But for other stuff, for like, for more complex conditions, the probability of being seen out of state is much more likely. And so I think there might be a difference for. I don't think there's a lot of issue for me, but I could imagine trying to use a similar approach for something that has more of a referral pattern would be a much trickier problem. I also happen to be in a fairly geographically large state in a county that happens to be right near the center, and to have probably the strongest medical services nearby. And so I suspect that there's not a lot. The issue that the New Hampshire folks are thinking about as far as people going to Boston to receive care, there's probably not something analogous in Seattle. But this is important for thinking about these kind of approaches in a lot of different contexts. I just happen to be in a place where it's probably less relevant.
Yeah, that's true. You might find on the eastern border of Washington a very different impact. All right, we do have a question that just came in the chat that I think that's a really good one. The question here: would you account for variations for weight if it was present in the sample across time?
Yeah, that's a great question. So I just took the last reported weight for each person in the data set, because I was the first for the comparison against the prior study. That's what they had done, and I needed to be sort of do an apples to apples comparison. But more generally, I think the right way to do this is probably to take one randomly. I'm looking now at the data within people longitudinally, and there's a lot of variation of weights over time. Within a person. Some of that is health driven, of course. Some of that is independent. Some of it is random noise. And figuring out how to deal with that longitudinally is going to be a big part of working with, these kind of data recorded in clinical settings for research purposes. Figuring out how to deal with fluctuation over time is tricky, and it's not totally obvious how best to do it. So thanks for asking.
Yeah, that was an excellent question. And I'll draw one more line to our first presentation. They spoke about missing data from out of state, in out of state context, things about military, prisons, other facilities that also are providing care. Did you see any of that variation? What are your kind of thoughts on that general sort of missing data piece?
Yeah, it's definitely an issue. I think my hope was that there's sort of no gold standard for what a population is. Populations are very variable and move over time. One thing about the being able to compare to the Burfus tool is that Burfus, by doing a sort of systematic sample, can be accounting for the sampling frame within Burfus, and the fact that our estimates were very similar to Burfus suggests to me that with a large enough data set, we're getting something very similar to the structured sample. But we absolutely are not including folks who don't receive care in any given system. Presumably, Burfus was also it's a phone survey, so it's limited to people with phones. There is probably underrepresentation of military folks who are present in a place, for example, but may not be their address of residence officially. And prison populations are another great example. I think people experiencing homelessness, it's unclear if you're migratory, which population you're sort of part of for what period of time. And so this is always going to be a little bit of a fuzzy definition. And I think, one of the things in sort of public health surveillance is always going to be doing the best we can to estimate what a population would be, but recognizing that the edges are going to be a little bit fuzzy.
Got it.
That's certainly present here. Thanks.
Yeah, that is interesting. Really excellent work, valuable work, and good to see some information coming out. Much appreciated. All right, next up, we have a presentation here from Sandeep Wadwa. Sandeep is a global medical chief medical officer at 3M Health Information Systems. And he's got a wonderful presentation about payment quality and other factors that impact Medicaid programs. So with that, I'll toss it over to Sandeep.
Good afternoon. My name is Dr. Sandeep Wadwa. I'm the Global Chief Medical Officer for 3M's Health Information Systems Division, and it's my pleasure to talk to you today for a few minutes about measuring data variation to maximize value. What I wanted to do is give a couple of examples of where data variation, payment policy, public reporting all come together to improve quality outcomes. I think we've known for a long time, and on the left is kind of the traditional approach to quality improvement. And I think on the right, you'll see kind of, I think, the gold standard alternative approach that's less punitive, that is more collaborative, and achieves to accomplish quality improvement in a much more collaborative, transparent methodology. The challenge that we've seen is that these approaches oftentimes are divorced or separated from payment policy. And what we've been working on and what we want to share is that the traditional standards of quality improvement can be incorporated into payment policy. And that adds another layer of impact along with public reporting and team-based quality improvement to driving results. And so on the left are some examples of traditional approaches to improving outcomes, and the alternative approaches are highlighted on the right. And when it comes to applying those into a payment policy, we can see all of those principles can be accomplished in payment policy. And so the approach we're talking about here is looking at prioritizing where a quality failure results in increased payment. And so that is an important area. If providers or plans or the system gets rewarded for a quality failure, that's low-hanging fruit. The incentives should be substantial enough to motivate change. So we're looking to impact payment policy in a way that gets people's attention, and it must be impactable. It's important for the providers to feel like on the payment side, if there's going to be an incentive or disincentive, that there is a logic model, an evidence model, that it's amenable to interventions. We are looking to not focus the conversation on how the change is impacted, but what change should be impacted, whether it is a surgical site infection or a central line infection. Let the providers figure out their approaches to solving it, but give them the parameters around what they'll be measured on. And then the other principle that we're incorporating here is focus on rates and populations than persons and individual cases. That system changes are easier to impact at a rate level, and that trying to put all the attention around individual cases can create some disincentives. Part of the process here, when you're taking quality and data variation to payment policy, is the importance of risk adjustment. It is very critical that one takes into account the patient's risk profile and comorbidity profile, because with more complex patients, there's a higher expectation of some outcomes, and you don't want to create a disincentive to caring for patients that are sick, and risk adjustment really helps to address some of those concerns. And then finally, avoiding a black box, that these processes should be transparent, all of the rules, there should be a clinical model, and that they're comprehensive, that as broad as you can be maximizes the impact you can have on a patient population, and that is, if you're following these other principles, you can look at a more comprehensive model. And so let me share with you a couple of examples of this in action. Let me start off with New York. This is a combination of a public reporting initiative, a payment initiative, as well as a quality improvement initiative. And the state of New York's Medicaid program made an effort to reduce potentially preventable complications. And this is summarizing kind of a 3-year, 4-year examination of that effort, where hospitals were evaluated on the potentially preventable complication rate, and their payments were adjusted according to what was observed. And so lower complication hospitals were paid more, and higher ones didn't receive those extra dollars. And you can see from a population perspective, from 2013 to 2016, we saw a 10% reduction in potentially preventable complications and a reduction of about 10,000 events per year statewide. And this is an example of how in the Syracuse region, several hospitals got together and made a collaborative effort around this initiative that was reinforcing. Not only was there a payment incentive and a public reporting incentive, we also saw the formation of local teams working together around a common metric. And we saw these results that are shared here with almost a 50% reduction in pneumonia rates, as well as almost a 25% reduction in urinary tract infections. And having a common framework that was tied to public reporting and to payment really achieved a common language amongst the providers here on how to measure their work. Likewise, the state of Maryland, in this example, is showing the results of a similar program that also focused on potentially preventable complications. And they noticed a 30% reduction in complications that then grew to a 50% reduction by the end of the 5 years. And they focused on complications around septicemia, severe infections, post-op hemorrhages, and the rest of the items I have on the slide. And I also shared the write-up from the New England Journal that supports this work. And again, we're seeing an example of the intersection of public reporting, payment policy, and collaboration. Switching gears a little bit to Texas. And in this case, this graph kind of shows potentially preventable readmissions with an observed over expected rate. And so you can see that on the right side of the graph, each of these dots is a hospital system. And each of these dots represents a higher than expected readmission rate. And on the left side of the curve, you can see lower than expected readmission rates. And so that forms the basis for their public reporting effort and payment policy, where they were geographically showing where the higher rates and lower rates of potentially preventable readmissions were occurring, and then could track that over time through both public reporting and a learning collaborative to kind of organize these 3 or 4 key principles that kind of interlock to achieve impact here. And you can kind of see a reduction in potentially preventable readmissions. And again, I think the data visualization has just advanced so much. And we're seeing here, I think, some very sophisticated data visualization where this data is showing potential readmissions, this inner circle having lower than expected rates of readmissions, about expected in this outer circle where we have higher than expected rates of readmissions. It allows for this practically real-time monitoring of performance and creating an environment for collaboration and also creating incentives for payment. They also, as we saw in Texas and in New York, the state of Texas also used that approach for monitoring and reporting and incenting reductions in complications as well. And we kind of can see results there over time. And again, I wanted to also show how a particular system, in this case, in El Paso, the university system, the University Medical Center at El Paso, was able to take these principles and apply them to their own environment. And in this case, not only have better patient experiences around readmissions, but also being recognized for delivering that higher quality of care in terms of extra incentives. And then switching gears to Florida. I thought the Florida example is an example of a similar application of these principles, but in this case, they're looking at emergency rooms. And I just think that this is a great example of how we can collaborate moving from inpatient care, complications and readmissions, to using the same principle to looking at potentially preventable emergency room visits. In this case, the potentially preventable visits were around upper respiratory infections, GI diagnoses such as abdominal pain, and you can see the geographic variation here with lower than expected and higher than expected rates of ER visits. And the state of Florida looked at this both from a managed care point of view with the health plans, as well as at a system and geography level. And here's the example of the reporting initiative for the managed care plans around potentially preventable emergency room visits. And you can appreciate the ranges of issues that are under consideration, as well as how they're displaying that information to the public and to the plans. And to conclude, I just wanted to share a summary slide that shows in multiple states that are using both combinations of payment policy, public reporting, site-specific reporting, and quality improvement efforts to really drive a reduction in potentially preventable quality defects. And I think this is work that we can continue to collaborate on and expand. A lot of this work has been in the Medicaid population, and I think there's opportunities to take this model to other populations, whether it's commercial populations or Medicare populations. And I look forward to your questions. Thank you. And here's my contact information. If there's any questions I can answer for you, please feel free to call, and look forward to staying in touch. Thank you.
Excellent. I want to thank Sandeep for that wonderful presentation. Really thought-provoking, a lot of good information there. I think a couple of things have stuck out that we should kind of follow up and address. Do the work that you've done, as well as the other presenters that we've heard from today. You mentioned something about having transparency is important, right? It's important not to have a black box system where providers don't necessarily know, or hospital systems don't necessarily know what they're going to get out of things. But I want to flip that around a little bit and talk about the fact that we've had 3 different looks at data today. We've had a government sort of look, we've had an academic look, and we've had a sort of more industry focused look. How does that change the perspective of the people that are doing the analysis and getting insights from that? And then what do you think that would do potentially on their sort of focus and prioritization based on that?
Yeah, thanks, Nick. I think the lens we've been taking is probably one of the payer and public payers at that. And so I think there's kind of 2 key accountabilities there. One is around the health status of the population you're serving, and measures that you're interested in around addressing health disparities and outcomes. And then the other is the efficiency of the program, Nick, and that we're using the taxpayers' money efficiently. And so I do think that probably serves as the lens from the payer's perspective, whereas I think when we heard from an academic and public health perspectives, I think that there's a level of detail that you're getting into in terms of hypotheses and rigorous research, as well as an all population, all payer perspective that we heard earlier from public health.
Excellent. So we did have a question coming through the chat that I think is a great one. The question here is, how are expected rates developed in states or cases that use an expected rate to visualize and or vary payment?
It is a great question. Usually that is set in partnership with the state. And so some states, what's important with each of the states in determining an expected rate is that it's achievable. And so you want, so some states used a top 25%, and they looked at the performance of the top quarter and used that as the goal for the rest of the system to emulate. And then other states sometimes will choose the top 50% and say that this is achievable results in terms of complications or readmissions, and that we're kind of looking to kind of create incentives and potentially penalties for those that are in a bottom half. So I think the idea that we've been promoting in each of these states is make sure that the expected rates are ones where the managed care plans or the health systems can see themselves, and not kind of ones that are not in the realm of realistic.
Excellent. Yeah, you brought up a lot of really interesting data here about, obviously the intersection between payment and public reporting and these health systems. And I was wondering if you have any insights that you'd be willing to share about some signals that may be over or underemphasized based on the data analysis that you went through.
Nick, it's been our experience that maybe the payment piece of this comes last, that the cooperative efforts and the public reporting efforts may often be the starting points and ways to get the community of stakeholders familiar and and then phase in a payment dimension to a quality defect program, Nick. So I think that's probably been the most common approach that we've seen. Sometimes these initiatives around defect reduction can kind of take on a budget hole dimension, and then they can all get launched at the same time.
Excellent. And then I have a sort of a big question I'll pose here. I understand that it's mostly it's a tough one, but how do you think that different data set access and use offer potentially different outcomes, and then sort of what can a policymaker or a policy setter use to kind of help mitigate that fact to as much as they can?
Nick, let me start that question. I didn't know if the other panelists also wanted to jump in on that, but we do a lot. We can do a lot with these administrative claims data, but some of the outcomes that were very interesting to me as a Medicaid director were what I was getting out of the survey information, and they were self-reported data from our clients themselves. And Nick, I still think we haven't, I think, solved yet. I'm not so familiar for where we can get patient-reported data kind of incorporated into some of these payment models.
Excellent. So as you see, we're bringing back our other presenters, and we've got a couple of minutes left for questions. If anyone in the group has one, don't forget to put them in the chat. But I know that I will answer that impossible question or spin that question out to others, because I'm curious about Jesse and Jennifer and Steve, your perspectives on that. If you have similar take on that, or if you have a different take based on where you sit and what sort of data you have access to. Whoever wants to go first can jump in.
I guess I would say I think this is the big, this was a big mean question. This is the thing that none of us really understand, and it's the sort of step that we really need to, I think, is understanding sort of how these different different data sets together give us a picture of the whole sort of puzzle of what the population health looks like. And I think I would argue that the sort of get all the data approach is an extremely good start to sort of figure out what these differences are. You have to have all the data, but the harmonization process by definition sort of rounds off the rough edges, and those rough edges are potentially also meaningful. So I would say that I would love to think that state or government organizations are leading this kind of approach, but that we're all going to sort of work together to think about what the biases are if we look at the data sort of without nuance as to where it's coming from. Sort of the blessing and curse of merging multiple data sets is that you get an aggregate picture that is less detailed than you would get within any given data set on its own. Curious what other folks think, though.
Yeah, I think in New Hampshire, we tend to mostly work with each data set by itself, whether it's vital records or it's hospital discharge or it's births. So we don't really have too much experience kind of joining data sets like this, although it's definitely an area that we could spend some time in. I think Jenny would agree, and it's kind of inspiring to hear these different talks and think about what we might do at the state level.
Excellent. Well, thanks. I know you're right. That was an underhanded question. I felt a little bad asking it, but I thought it was important to bring up seeing the three different perspectives we've seen today. All right. I want to thank all of my speakers today, Jesse and Jenny and Steve and Sandeep. Wonderful presentations about measuring variations in health utilization. As you saw, I believe that most of our speakers have shared contact information, and I'm sure would be willing to talk about future questions or issues or other things that you guys may have thought of question-wise or other during the session. So I would encourage you all to reach out if you do have those sorts of questions for further discussion. And I wanted to thank everyone for their time today.
Thank you again.
Thank you.
Thanks.
Thank you.